thank you for coming here for this symposium. I want to thank Ron Tamler and Yaron Tomer. I had to practice this. It's Ron Tamler and Yaron Tomer for inviting me, and also for making me the first speaker after lunch. That's always, that's always great. So to just wake you up from your postprandial dreams, just a quick question. How many of you see patients with PCOS? Not that they're referred to you. Oh, a lot of people. Okay, so you're familiar with this condition. Then I would ask you the next question. How many therapies, medications are currently approved to treat PCOS? Any? One? Which one? Metformin is approved now, you think? Yeah. According to what? So unless something changed very recently, there is currently no approved treatment for PCOS. So everything you're doing with these patients is off-label. We'll talk a little bit about that. That is why also in your packages, when you come to disclosures, it says that I'll be discussing some unapproved treatments. Now to move forward, this is what we're going to try to cover in about 30 minutes. And this slide lists the features of PCOS. And they're in disarray here, not because I was under some sort of influence when I was making this slide, but because we really don't understand very well how they relate to each other. Some of this is understood. For example, as much as we know about the relationship between insulin resistance and obesity, we don't understand it completely, but at least we know that there is an association. Hyperinsulinemia, hirsutism, and hyperandrogenism, of course, are related. But it is really still very difficult to put this whole picture together. For example, how do large cystic ovaries develop? So there are many theories, and I'll show you one of those that we have developed over years. But the take-home message still is that this disease is not understood. We really don't understand the pathophysiology of PCOS. Can you hear me? Yes. So the modern history begins with this paper that was written in 1935 and described the triad of amenorrhea, hirsutism, and infertility in just 7 patients. This is the table from Stein-Leventhal's paper, and as you could see, all of them had these many follicular cysts that they found in the ovary. Now, this description, I think, is maybe the best of polycystic ovary morphology, so I think it's worth reading it, even though we have little time. The cysts were follicle cysts near the surface, maybe I'll look this way, and almost entirely confined to the cortex, and they contained clear fluid. There were from 20 to 100 cysts in each ovary, varying in size from 1 millimeter to about 1.5 centimeters, but rarely larger. The color of the ovary was oyster gray, with bluish areas where the cysts were superficial and appeared on the surface as sago-like bodies. On section, the variation in size of the cysts and the clear fluid contents were revealed. Corporal lutea was sometimes absent, and when found, they were very small and deeply placed. So this is also the figure from the same paper. Stein and Leventhal proposed doing these ovarian wedges. They would remove part of the ovary in this wedge form, and you can see these subcapsular cysts. This is the capsule here. And this treatment was actually very successful in inducing ovulation, reducing hyperandrogenism. Nobody understood it then. Nobody understands it now. But it did work, but it did produce a lot of side effects in terms of adhesions and other problems with fertility in these patients who already had fertility issues. So this treatment eventually was abandoned. This is a more modern picture, and maybe you can just focus on these ovaries here. These are these large cystic ovaries with thick capsule. And I don't know if we can lower lights for just a minute. If we can, you will see these little cysts, like a string of pearls, that are right under the capsule. So what are these cysts? it turns out they're actually follicles. They're pre-ovulatory follicles. They are there. There are many of them, as you can see. They're just not ovulating. So this condition essentially morphologically consists of an ovary with a lot of follicles that are ready to go but are not ovulating. And that's important to remember, because as you begin to treat these patients, you want to avoid hyperstimulation syndrome. There's a lot of follicles that if you do something in terms of ovulation induction that's very dramatic, you may produce hyperstimulation syndrome. What are the hormonal abnormalities? One interesting finding is elevated luteinizing hormone levels, not in all patients, but in many patients. This is a slide from one paper that looked at that by Barney Zumov many years ago, actually. It was published in New England Journal of Medicine. And you could see that this LH is pulsing here. FSH is present. It's not absent. You can measure it. This is the concentration. Sorry, this is the FSH concentration here. But it's clearly at a much low, is present at a much lower level than LH. Why would that happen? Well, having heard everything I said before, you'll realize that we don't know why the LH is increased in these patients. But it is a real finding. And one explanation is that perhaps insulin, since these patients are hyperinsulinemic, is stimulating LH secretion. And indeed, in vitro, you can show that if you culture pituitary cells and make them and use GnRH to produce either FSH or LH, and then you add insulin, you can magnify response to GnRH many-fold. But you can do it for both FSH and LH. Why in patients with PCOS, if this is the mechanism, only LH is increased, we don't know. Of course, the important other finding is that the free testosterone level in these patients is increased. It is certainly driven by LH, that we know, but also, again, insulin can be shown in vitro, not so clearly in vivo, but certainly in vitro, to increase concentrations of testosterone that are made by ovarian cells. And before the lecture, I was asked informally about these adrenal androgens. So adrenal androgens are sometimes elevated in these patients. The cause is unknown. Various explanations have been proposed. One of them was this putative hormone that, similar to ACTH, would stimulate just androgen secretion from the adrenal glands, but this hormone was never identified. So again, why in some patients there's a predominant elevation of adrenal androgens, we don't understand, but we do see that. What is the evidence for insulin resistance in these patients? This is a study by Dr. Dunaive, who used to work at Mount Sinai, actually. And as you can see here, if you look at either obese or lean patients with PCOS, and you do a glucose tolerance test, you will see that in lean patients, glucose concentrations are normal. In obese patients, they're a little bit abnormal, but they're not in the range of diabetes on average. But in both groups, whatever glucose level you're maintaining it at the cost of high insulin levels. So both lean and obese patients with PCOS are commonly, although not uniformly, but commonly insulin resistant. And this is a clinical manifestation of insulin resistance, acanthosis nigricans, which you can diagnose, in checkout lines in supermarkets sometimes. I'm sure you've seen that. This is actually not a hyperpigmented skin so much, but thickened hyperkeratotic skin. So hyperkeratosis and what is called papillomatosis, just thickening of the skin, produces this darkening. And if you touch it, it has this velvety appearance because of papillomatosis. And this is a clinical marker of insulin resistance. How it develops, we really don't know, but it is thought to be an effect of hyperinsulinemia in the skin. So if these patients are insulin resistant, and yet we're saying androgen production in the ovary is driven by hyperinsulinemia, at least in part, how can the ovary remain sensitive to insulin when other targets, classical targets like fat, liver, or muscle, are insulin resistant? Well, there are a couple of explanations. One is that after insulin binds to insulin receptor, there is a divergence of signaling pathways that can occur. And for example, glucose transport pathway may be different in terms of components than, for example, some other metabolic effect. And you could imagine that, let's say, glucose transport is impaired so that patient is indeed insulin resistant in terms of glucose transport, but other pathways may actually be hyperstimulated because of hyperinsulinemia. So if one were to become a little more specific about it, after insulin binds to insulin receptor, a number of events occur that lead to the translocation of glucose transporters to cell membrane, and then glucose can enter the cell. This is the main effect of insulin. And the key enzyme in that effect is an enzyme called PI3 kinase. Now, we have been able to show that actually activity of this enzyme is unimportant for the effects on steroidogenesis that insulin has in these cells. So there's some experimental evidence that you can actually separate these various effects so that glucose transport, at least theoretically, might be deficient, but others might be amplified because of hyperinsulinemia. Another explanation is that insulin receptors are not the only mediators of insulin action in the ovary. In fact, another group of receptors are the insulin-like growth factor receptors, or IGF receptors. To make things a little more interesting, there are also hybrid receptors that are half insulin, half IGF-1 receptor. Now, we have shown early on in animal studies that if you create experimentally hyperinsulinemic rats in this case, you will downregulate insulin receptors in the ovary, as you would expect, but IGF-1 receptors are actually doubling in number. And this was shown later to be also the case in patients with polycystic ovary syndrome. The IGF-1 receptor number is increased. Another thing that's occurring under the effect of insulin, and this is a very clearly established effect, is inhibition of sex hormone binding globulin production in the liver. This is our study, but there are many other studies that support that. And of course, if you reduce sex hormone binding globulin concentration, your free androgen concentration would rise. And finally, there are these proteins called IGF binding proteins that bind IGF. One of them, IGF-BP1, is actually insulin sensitive, so its concentration, similar to SHBG, is reduced under the effects of insulin. The previous slide was systemic circulation. Here we show our early data in the ovary. So as a result, you have a somewhat complicated system where you have, let's just forget IGF-2 for the moment, but you have two hormones, two ligands, insulin and IGF-1, and you have two receptors that can mediate their effects, and you also have 6 binding proteins, but only one of them is insulin sensitive. So, not to go over it, but interactions get pretty complicated, and the only reason I'm showing it today is because I don't think when you look at the effect of insulin on androgens, it's simply direct stimulation of insulin of androgen secretion. Insulin probably amplifies this IGF-1 pathway as well. So these are some of the effects that insulin has in the ovary that are summarized from the literature. Some of them are actually not in the ovary, but in adipose tissue, for example, effects on aromatase, or liver, effects on IGF-BP1 or SHBG. But there's a variety of effects by which insulin can affect female reproduction. What happens then if you combine this elevated LH level and hyperinsulinemia? These studies we did in animals a little while back, actually I think when Beth Israel was still part of Mount Sinai. This was our first coming, so to speak. This is now second. And we had these hyperinsulinemic rats developed with a variety of hormone treatments. Our major group that we were interested in was the group that received insulin and HCG, which is very similar to LH, and also GnRH antagonists, so we blocked any effects on the pituitary, so we were looking just at the effects directly on the ovary. And without much detail here, you can see that using this kind of approach, you can develop in an animal large cystic ovary. So this is that theory that I kept promising you at the beginning, and of course it's not definitive, but one way one could explain all of the features of PCOS, which are listed here at the end, that if you have two defects, some defect that causes this hypersensitivity of LH to GnRH, possibly because of hyperinsulinemia, and another one which produces insulin resistance, you could actually, through a variety of mechanisms, arrive at all of these findings. And the mechanisms involve not just direct action through insulin receptors, but also amplification of IGF-1 system because of inhibition of IGF-BP1 and increase in IGF-1 receptor number. So the condition, as you all know, is really very common. Depending on which literature you read, you will arrive at 6-12% or even up to 26% of women of reproductive age. The commonly cited number is 5 to 10%, so obviously very common. And the diagnostic criteria that we use can be either one of these three sets. There was an NIH set developed in 1990, which a lot of us still like. There were subsequent Rotterdam criteria developed, and then Androgen Access Society criteria. They're really very similar. You don't need to look at them in detail. They require that you have evidence of hyperandrogenism, either clinical, like hirsutism, we'll get into that a little bit in a few minutes, or biochemical, elevation of free testosterone or other androgens, presence of anovulation, and then you may, depending on the set of criteria, you may or may not have to demonstrate actual polycystic ovaries on ultrasound. So NIH criteria doesn't require that at all. Rotterdam criteria says that if you have that, that's good. But you only need 2 of 3 criteria, so you really don't have to have this. And the Androgen Access Society criteria includes polycystic ovarian morphology under this ovarian dysfunction. So it doesn't have to be necessarily this. So I guess in practice, all it would mean if you have a young woman with menstrual abnormalities and evidence of hyperandrogenism, if you exclude other causes, and that is present in every one of these sets, then you can make diagnosis of polycystic ovary syndrome. You don't necessarily have to demonstrate actual polycystic ovaries on the ultrasound. Because of technical reasons, it's not always possible. Genetics are interesting. In many ways, this condition is similar to diabetes in that it's very common, it's characterized by insulin resistance. The cause is not understood. We all know that we don't know the cause of type 2 diabetes, right? The cause remains unknown. But there are many genes that have been implicated. And there is familial predisposition. For example, in this twin study, you could find concordance of almost 70% in monozygotic twins and up to 40% in dizygotic twins. This is just the list of genes that have been looked at, but at the end, today, in what we call garden variety PCOS, we really don't know what the genetic abnormality is. With some rare exceptions where there are insulin receptor mutations with syndromes of extreme insulin resistance, we really don't understand specific molecular defect. Clinical manifestations fall into these 4 groups. So menstrual irregularities, other evidence of hyperandrogenism, insulin resistance, and obesity. Now, hirsutism is one of those things we kind of know when we see it, although one has to be careful in terms of some ethnic groups. But you could use, if you want, Ferriman-Gallwey score to quantify it, although mostly it's used in a research setting. You look at the variety of areas, it's up to 19, I think, today, and I'll show them to you in a minute. And you grade hair, presence of hair or absence of it, from 0 to 4. And if you get a total score of 8, so even if there are just 2 areas with a lot of extra hair, you can make diagnosis of hirsutism. And these are the 19 areas really essentially everywhere. Now, the treatment. And I'll spend the last, I guess I only have 5 or 6 minutes on this. As I mentioned before, no approved treatment, no FDA-approved treatment for this condition. Doesn't mean that we don't treat it, and actually sometimes even effectively. So one treatment option, well, before we get to those, I personally think that treatment should be symptom-driven. You really have to ask the woman, what is it that bothers her most? Some may come because they're worried about menstrual irregularities, others because of, say, hirsutism, others come for infertility, and others because they're worried about risk of diabetes. And then you treat the condition that worries the woman most. Weight reduction has been shown in many, many studies very effective. I'm told there are many nutritionists here, so you can try this diet if you want. 350 kilocalories a day. What is it for 4 weeks? You'll probably lose weight, and if you have PCOS, some of your symptoms may improve. But it doesn't mean it's really super effective way of treating it. There are very minimal data on bariatric surgery, just a couple of small studies, as you can see. But again, you can improve ovulation if you reduce weight. The mechanism is thought to be related to reduction in hyperinsulinemia and insulin resistance with weight loss. You can use oral contraceptives primarily for treating symptoms of hyperandrogenism, like hirsutism, for example, and also establishing kind of regular periods, although, of course, this won't be ovulatory periods. But if the woman is really interested in establishing regular periods, then oral contraceptives can be useful as well. Metformin, that to my knowledge is not approved for treating PCOS, but I'll double check it after this lecture, can be used and has been used. Of course, it has a variety of metabolic effects. Most of them, as we learned relatively recently, considering that this drug has been around for 50 years, I guess maybe 10 years ago we learned, or maybe even less than 10 years, that it acts through AMPK, but it also has reproductive effects. It does lead to increased ovulation rates, particularly in clomiphene-resistant patients. But interestingly, if you compare it to clomiphene, as a single agent, it doesn't really improve what we call the take-home baby rate, which is the actual live birth. So you may improve ovulation, but not necessarily live births if you use it for treating infertility. PPAR gamma activators can be used. Of course, they also reduce insulin resistance by activating PPAR gamma, but they also have their own direct effects in reproduction. I will skip this slide quickly. And this is something we reported relatively recently, where we looked at direct effects of TZDs in the ovary, and they actually have a lot of direct function, even without insulin, just in vitro. You can improve androgen levels using this approach, and you will improve ovulation, as I mentioned before. But you are placing these patients, as you know, at some risk. I'm not so sure about the cardiac events. I don't think that's really real, except for congestive heart failure in much older patients. But certainly, again, in older women, you can see increase in fractures, about doubling in fractures. This is the data from the ADOPT trial. Why is this occurring? We looked at some of it in vitro, and it turns out these agents, if you use, in this case, mouse osteoblasts, will inhibit the growth of these cells. So this would be control, this will be pioglitazone, this will be rosiglitazone. And the way they do it is kind of interesting too. I'll just amplify this area now, and you'll see that these are control osteoblasts growing, and this is what happens in the presence of rosiglitazone or pioglitazone. You actually have a lot of differentiation towards adipocytes instead of bone cells. And that is probably the main reason why these patients have an effect on bone density. GLP-1 receptor agonists act primarily because of weight loss. Again, there's a variety of trials, and we look at them. And with weight loss, you can improve ovulation rates. You can see here. And in terms of anti-androgen effects, you can either use spironolactone, which is, of course, an androgen receptor blocker, or finasteride, which blocks 5-alpha reductase. So you block the formation of dihydrotestosterone, which is the active form of testosterone. But you have to be careful, particularly if these women are trying to get pregnant, because these anti-androgens could have undesirable effects in the fetus. And finally, treatment of infertility is maybe the most important reason these women come to us. The first line is usually clomiphene citrate. This is an estrogen receptor antagonist, and if you block the estrogen receptors in the pituitary, FSH secretion will be stimulated, and that leads to follicular growth. It's a simple course of treatment, and a lot of time will produce ovulation. But if that doesn't work, and this usually is done by reproductive endocrinologists, by gynecologists, not by internists anymore, you can use the gonadotropin cycles. Sometimes you could use aromatase inhibitors. Again, because of reduction in estrogen level, FSH will rise with effects that are similar to clomiphene citrate. And then you can use in vitro fertilization. Because of time, I won't go into all of these. If the predominant elevation of androgens, if androgens that are elevated are predominantly of adrenal origin, you can use glucocorticoids, although it's seldom needed to treat fertility. And then you may remember one of the first slides I showed you those ovarian wedges that Stein and Leventhal used to remove. There's sort of a more modern version of it. It's called laparoscopic ovarian drilling. It literally consists of drilling these holes, not by internists, of course. I hope. And that does produce improvement in ovulation. Mechanism really continues to be unknown. So in conclusion, PCOS is a heterogeneous disorder of unknown etiology. There are many therapeutic approaches. I think they should be symptom-driven. Future research may allow improvement of our treatment and more focused treatment. And if you do everything well, this treatment actually could be very rewarding. Thank you very much.